Is it visible, sir?
Yes, to me.
Visible but not moving.
Okay. I'm resharing it. Sorry about this. Is it visible now? Can you see the agenda slide?
Yes.
Yes, just now we can.
So my apologies. So the idea of this program is to, because it's been almost 1.5 years since we have introduced Biotronik connection system tools, especially in India, and some of the sites have some experiences. The idea is to, bring together different challenging cases from centers which have done really quite a few cases. So today we would have Dr. Harunburi and Dr. Karthikesh share their experiences, and they'll be learning which all of us would want to involve. So please be engaging in a panel discussion, and we might kind of make it a bit more interactive as Dr. Harunburi has suggested. So I'll hand it over. So before I hand it over, one last announcement. We have please unmute yourself, ask questions, because it's a very small group and we would want some interaction, and the recording of the program would be shared after the the end of the program. Over to you, Dr. Narasimhan. Thank you.
Thank you, Ayush, and I would like to thank Dr. Harunburi for making it possible, and again for Biotronik for organizing such a good meeting, which is the need of the hour now, because there's an emerging data about the efficacy of left bundle branch block, but still there are a lot of left bundle branch block pacing, and there are a lot of unknowns in this area. And we would like to hear more about this from Dr. Harunburi, who's the Director of Cardiac Pacing Unit at the University Hospital of Geneva at Switzerland. And he has been very active in the EHRA and in the conducting scientific and educational programs all through the Europe. And it's indeed my pleasure and privilege to invite Dr. Harunburi to talk about this topic. Harun, it's all yours. I think you're muted. You're still muted.
Sorry. So can you hear me now?
Yes, loud and clear. Please go ahead.
Yep. Play around with that. So I'll show you a few cases and start off with. Hang on, there we go. There, perfect. Can you see that now? So this is a patient, 68-year-old male who has Mobitz 2AV block. You can see the ECG with 221 AV block or 322 AV block, right bundle branch block morphology, left axis. He's symptomatic but has a normal ejection fraction. So any patient who needs frequent ventricular pacing in our hospital 2017 will receive conduction system pacing. In this instance, I opted for left bundle branch area pacing. So this was using, in fact, a stylet-driven lead, the Solia lead, and they have a guiding catheter, as with the lumenless leads. So you'll see different screens at the same time. Everything is really in real time. And we're basically also have a Y connector to the EP system. And you can see that here we have infranodal block. You can see very clearly an A, a very sharp hiss without a V. Note also that I'm mapping the hiss with the stylet retracted. And I think that's one of the advantages, because the helix gets easily snagged onto the tricuspid or valvular apparatus or in the annulus. And to be able to move it around freely, I think is quite an advantage. And you get very nice, crisp signals, as you see here. So we've got infranodal block. And once I've mapped the hiss, But I only look for the His for a couple of minutes. If I don't find it, I don't keep insisting, because you get a good idea where the tricuspid annulus is by the movements of the catheter and also by the EGMs. But if I do see the His, then I will screenshot it to then have a reference point to place my lead thereafter. So here we have the His, and now I'm going to move the guiding catheter in. So I'm working in RAO. The helix is still retracted. And again, this allows me to move around very freely without snagging anywhere. So this is more or less the spot I want to get to in RAO. It's about 2 centimeters towards the apex from the His. In Europe, we go a little bit more distally than the Chinese do. The Chinese pace very, very proximal, say 1 to 1.5 centimeters. We tend to go more mid-septal. There's a study which shows that you have probably a slightly more lower risk of tricuspid regurgitation there. And also, in my experience, the septum is easier to penetrate at that spot. Now over to LAO 30, and I'm doing the pace mapping. Note that in lead 2, we're more or less isoelectric. Lead 3, negative. That's fine. Lead 2 can be positive or isoelectric. Sometimes it can even be negative if you try new spots. We also look at lead V1, and what we like to see is a sort of a W pattern or notching, but it's not absolutely obligatory to have it. You can still get conduction system capture without having the W pattern. And it's also very important to look there are also later on in V6 for the R wave peak time. So now that I'm in position, I'm happy with this position. What I'm going to do is I'm going to, so this is just the ECG for you to look at. Now I'm going to extend the helix and actually use it with the green funnel tool. You can also use the white tool that you have, but the green one, which is stuck on, does a very good job. And you can just twiddle it, and you can see now that the markers are separating. That indicates that the helix is being extended. And I, in fact, give extra turns to keep the torque buildup within the inner coil. That's to avoid the helix from retracting. And now what I'm doing is I'm screwing in the outer body of the lead while monitoring the impedance. So what I'm looking at is the way the lead is moving forward. Very often it's quite subtle, okay? But sometimes you do see it going forward, and that's a good thing. I'm monitoring the pacing impedance, which is 623. It was higher initially, so the impedance goes down. You have to be careful when you reach about 500 ohms, because if it goes down further, or in fact less than 450, you maybe you've perforated. And the other thing I'm looking at is the electrograms and the ECG while pacing. So please note that you see the crocodile clip is actually clipped onto the stylet in unipolar mode. So the anode is actually to the skin clamp, and this is really useful. So you can actually monitor the ECG, you can monitor the pacing impedance while continuously screwing in. I think that's a major advantage. Whereas with lumenless leads, unless you have a homemade tool, you need to clip, unclip, clip, unclip all the time. And this basically just allows you to screw in continuously. What we see here is there's a small R wave that's growing in lead V1. And we also see that in V6, the R wave peak time has got, the slope is steeper. What we also see here is a fixation beat. You can see these template beats which come about by, which are mechanically provoked. So initially they look very much like what we had initially with that W pattern in V1, and these template beats move more and more towards what we aim to get. So I'm continuously pacing. I'll just depause that. And here you see that the R wave has grown quite a lot suddenly. And in fact, the R wave peak time in V6 has gotten a lot shorter. So at this stage, I'm stopping. So I just did this continuously without stopping. And you can see here just a frozen image of initially in V1, negative, some template beats initially. And here we have an R prime, which is growing. And so now we have that R prime, which is getting bigger, a template beat here. And suddenly you see a very
Recording in progress.
What we look at is the V6 R wave peak time, 64 milliseconds here. For someone who has a narrow QRS or a right bundle branch block, isolated RBB. Now, patient, he also had the left anterior hemi block. We want it to be less than 75 milliseconds, which is the case here. And we want ideally a V6 to V1 interpeak interval to be at least 33, ideally more than 44. That was found to be 100% specific. I'd also like to insist that none of these electrical parameters are 100% sensitive and 100% specific. Okay, they're not 100% accurate. It's always a trade-off, what cutoff you use, how sensitive and how specific you want to be. And that's why it's very useful to use multiple parameters to decide if you've got conduction system capture or not. Here with an R wave peak time of 64, less than 75 is 100% specific, so I'm very happy with this. We also routinely measure the QRS duration from the spike to the end of the QRS, which is usually quite wide, 148, but note there's always some latency, which is about 20 to 40 milliseconds. So the actually sharp upstroke of the QRS to the end of QRS here is only 106 milliseconds, which is narrow. So I'm happy with this. What I'm stopping to pace, and what we see here is a fascicular potential. Okay, so here with a fascicular to R to V of 38 milliseconds, which is sort of long, but this patient does have infranodal conduction disease, so that probably explains why it's so long. What we also like to look out for is if there's a current of injury. There's maybe a bit of current of injury here. That's why I have the non-filtered electrogram on top of the filtered one. And of course, a nice big myocardial electrogram. So I'm happy with this, and we're going to, and you see the myocardial potential current of injury. That's also something really important to monitor. I'll show you why later on. The thresholds are very good. Usually thresholds are not a problem with LBBP compared to HBP. And here I've slit the guiding catheter. You need to adjust the slack. One thing I always look at after is if that potential is still there of the fascicular potential. As it is, you can see on the screen right there, it's still there. So the lead has not moved at all. And well, the final result is good. And this was really a very straightforward case. What I suggest we do perhaps is we discuss each case as we go along. I've got 45 minutes, so we've got time to discuss the cases. Are there any questions or remarks before I move on to the next case?
Very nice case, and very well demonstrated the fascicular potential, how the R wave peak time shortened abruptly, and we'll open this up for discussion. May I invite comments from Dr. Neeraj Yadav? Neeraj, are you there?
Yes, I'm here, sir.
You can unmute yourself, and we can see your face. You can share your video too.
Yes.
Okay.
So it was an excellent case, and it was a nice technique. Actually, we even with steroid-driven leads, we still clip and unclip. But this is a nice way to continuously monitor impedance as you screw in, and that is probably the advantage which we don't have with lead which does not have a lumen. And initially, we used to give a lot of emphasis on electrogram, finding out fascicular potential, but sometimes when we do these cases in different hospitals, 12-lead ECG and the entire criteria of left bundle capture is solely based on the ECG, 12-lead ECG. Yeah. But those were very beautiful potentials to look at and very reassuring that capturing very nice case.
Let me just ask, what are the problems that anyone has faced in this stylet-driven lead?
Yeah.
Or even other things. Let's have some discussion.
So, sir, what I have seen with stellar-driven lead, which I had not experienced with Medtronic 3830 lead, is the sometimes, particularly when we are tackling fibrotic septum or probably the tricuspid leaflet, the entire helix get distorted. It gets stretched out when you're pulling, and so I have encountered it a couple of times where I have to then change the lead. So I just want to know what actually leads to this phenomena where your helices entirely get straightened out when you try to remove from that spot. It's not moving in. I think it is probably
We
either
heard you. We'll get Haran's thing on this. Haran?
Yeah.
You
So
heard got the
indeed,
question.
absolutely, it's about helix damage, which is an issue. Probably more of an issue with the stylet-driven leads than the lumenless lead, because the helix of the lumenless lead is very robust, but it can stretch as well. And I've stretched a lot of helixes of lumenless leads when I was doing His bundle pacing more frequently, because you're screwing it into the fibrotic tissue. And sometimes it's very difficult to pull it out. You have to pull really hard. It doesn't come out, so you just have to pull a bit harder until it does, and you see some fibrotic material on the end. And the helix is stretched out, even with the lumenless leads. But the lumenless leads are more robust. Now, with the stylet-driven leads, for His bundle pacing, I think that's an issue. When you try to go to the His and you have to reposition, you've screwed the lead into the His, and to reposition it can be an issue. And I started doing this, then I stopped with the stylet-driven leads. But for left bundle branch area pacing, it's actually not so much of a problem. One thing you have to be very careful about, and that's not only with stylet-driven leads, but also lumenless leads, is the entanglement effect. Marek Jałszewski from Poland presented a paper in Europe a few years ago in Human Cadavers, where he described different phenomena. You have the entanglement effect, which is quite frequent. I forget the exact percentage, but maybe